Good evening, everyone. My name is Michelle Galazewski. I'm a Partner Relations Director with Eversight, and on behalf of everyone at Eversight, I would like to thank you for joining tonight's program, Clinical Management of HSV Keratitis and Preventing Infection at Tissue Procurement. In an effort to eliminate all background noise, all participants will be muted throughout the duration of the webinar. If you would like to ask a question, you can do so by typing your question into the Q&A panel at the bottom of your screen, and then we will address all questions at the end of the webinar. At this time, I would like to introduce our speakers for this evening. Dr. Mohammed Dastjerdi is an ophthalmologist and assistant professor at Rutgers, New Jersey Medical School with specialty training in cornea, external disease, and refractive surgery. Dr. Dastjerdi earned his medical degree from Tehran University of Medical Sciences and completed an ophthalmology residency at Kansas University Medical Center. He finished a clinical fellowship in cornea and external diseases at Michigan Medicine's Kellogg Eye Center, and he also completed a research fellowship at Harvard's Shepins Eye Research Institute at Mass Eye and Ear. As Director of Research at Eversight, Onkar Sawant is responsible for all research and development activities, in addition to leading the Eversight Center for Vision and Eye Banking Research located in Cleveland. Dr. Sawant received a doctorate in biomedical sciences and master's in biotechnology from Texas A&M University. He completed a postdoctoral fellowship at the Cleveland Clinic Cole Eye Institute and was named an emerging vision scientist by the National Alliance for Eye and Vision Research. Onkar was featured just last week in Newsweek for his ongoing research on the effects of COVID-19 on donor tissue. Dr. Dastjerdi, you can go ahead and begin.
Thank you, Michelle. And before I start, I would like to thank Eversight for inviting me to have this presentation tonight. So I'm going to talk about HSV keratitis, and my main focus tonight would be on treatment and prevention. And I have no financial interest to disclose. So herpes viruses in general, they are double-stranded DNA viruses, and they have a viral envelope lipid bilayer. The point is here that this herpes viruses, because of this envelope lipid bilayer, they are not able to maintain their infectivity in the environment, and they quickly basically deactivate it. And it's very hard to transmit iatrogenically through the medical instrument, and we can easily clean the instrument in terms of the HSV with the alcohol. And we have 8 human herpes viruses. 6 of them affect human eye. And from those 6, herpes simplex type 1 and 2 and varicella zoster virus are the most 2 important viruses that affecting the eye. And interesting point here is that all herpes viruses establish as a form of latency in their host. For example, HSV type 1 and 2 and VZV establish latent infection basically in dorsal ganglia such as trigeminal ganglion. And Epstein-Barr virus has a latency in B lymphocytes. And let me start, and my main talk today is going to be on herpes simplex virus keratitis. And I will start with epidemiology. HSV is endemic throughout the world. Humans are the only known natural resources reservoir for this virus, and nearly we can say 100%, or better, we can say more than 90% of people above age 60, they are seropositive for this virus. And a study in a cadaver shows that 60 and above, they have this virus in the trigeminal ganglia. And about 1/3 of world population suffer a form of recurrent infection. I'm not talking about the ocular infection, any form of HSV infection. And HSV mainly transmitted through the direct contact with the infected secretion like saliva or tears. And seroconversion mainly affected by degree of exposure. And that depends on the crowding, poor hygiene, and age. For example, in kids less than 5-year-old, there is a study that in low social economy group kids before age 40, before age 5, they are about 40% seropositive compared to 20% in middle class. So HSV keratitis is the leading infectious cause of corneal blindness among developed nations. And it's estimated that about basically 5 to 15 cases per 100,000 population per year, we have new cases. And in terms of the recurrence, about 30% we have a recurrence within 12 months. It's estimated globally about 1 million new cases each year and about 9 million recurrent episodes of ocular HSV each year. So it's quite a burden because all these patients need to be seen by an ophthalmologist, and also loss of productivity and time that these patients spend out of the work. And actually, the effect on the vision might be significant. And in terms of recurrence, I just want to bring this to your attention that we may always talk about the recurrence, but we have different form of recurrence. Let me, to explain this, why I'm talking about different recurrences. Let me bring this example. If we have an epithelial keratitis and subsequently we got a recurrence, epithelium to epithelium keratitis is about 15% chance. But non-epithelial HSV ocular disease to epithelial is about 12%. So it's almost the same. But look at the stromal keratitis. The stromal to stromal recurrence is about 28%, while non-stromal HSV ocular infection to stromal is about 3%. And this is something that we need to keep in mind when we wanted to initiate prevention for this, preventive treatment for these patients. The other thing about the recurrence, the number of recurrences is strongly associated with the number of past episodes. So for that reason, we can say a history of HSV stromal keratitis, emphasize stromal keratitis, and a high number of previous episodes increases the risk of future recurrences. So that's a very important point. And the other thing, shorter intervals between attacks also associated with the shorter interval between the future attacks. And in terms of the clinical manifestation, I don't want to go to the details of the clinical manifestation of different forms of HSV keratitis. My main point here is that HSV keratitis affecting different corneal layers has functionally distinct mechanism of pathogenesis. And for that reason, we're going to target our treatment differently. So if we look at the classification of HSV keratitis, so it affects all layers of the cornea. If it's in epithelium, we may have dendritic or geographic epithelial keratitis. Here, we have live and direct virus invasion. So that's something that I just want to bring to your attention, because when we start the treatment, this is going to be helpful. Also, we have a stromal keratitis. We have two types of stromal keratitis. Stromal keratitis without ulceration. Mostly we refer to that as interstitial keratitis, and HSV keratitis with ulceration or necrotizing keratitis. In HSV stromal keratitis without ulceration, main mechanism is the immune mechanism. While in stromal keratitis with ulceration, we have both. We have live viruses and we have immune mechanisms also involved. In endothelial keratitis, the main mechanism, immune mechanism, although we may have live viruses as well. And this classification can help to strategize our treatment. In terms of the modifiers, there are different modifiers that, it affects the severity and the clinical presentation of the disease. So we may consider HSV virulence, although in animal studies, it shows that different strains of HSV can have different, virulence, but in the human, so far, no study shows that different strains have different infectivity. But in terms of the host, we have two different factors: general susceptibility of the host and local susceptibility of the host. Then I'm going to talk about this. In regard to general susceptibility of the host, basically any condition that depresses the cell-mediated immunity may increase the risk of HSV disease, like organ transplant recipients, diabetes mellitus is very obvious. In these cases, we have higher risk for HSV keratitis and recurrence of this infection. Patient with measles, the area that is still measles is prevalent because of the, while the disease is active, we have a cell-mediated immunity, basically that is not functioning well. We may have an increased risk of HSV keratitis. In HIV, although the studies didn't show that the basically incidence of the HSV is not higher in HIV patients, but the recurrence rate is much higher in patients with HIV infection than non-HIV patients. And in terms of the, also we may have altered immune system, and in terms of that, we can look into children and patients with atopic disease. In children, we know that we have more bilateral disease. In adults, we rarely see as a bilateral disease. In children, the other things we may see epithelial and stromal keratitis at the same time. This is very rare in adults. We have higher recurrence rate in the first year in kids, and commonly misdiagnosed because the clinical presentation might be not that much classic. And the other thing, because we have a very severe inflammatory response in kids, they develop significant scarring and loss of vision. And so for that reason, kids need more attention when they get HSV keratitis. And in terms of the atopic patients, we define the atopy as a personal or family history of asthma or other form of atopic skin eczema. And we know that in atopic patients, Th2 cell immunity is more active than Th1. So the balance tilted more towards Th2, which led to synthesis of IgE antibody and production of eosinophil. And for that reason, Th1 is not as active as it should be. And again, we may have more cases of HSV. And the other thing with atopic patients, the risk of getting HSV is about 2 to 5 times higher than non-atopic patients. And we have more severe form of HSV keratitis. We have more bilateral diseases. And also the other interesting thing that the therapeutic response to topical antiviral is significantly less than oral agents. And that also is a point that when we wanted to initiate treatment for this patient, we need to take it into consideration that the topical is not as effective as oral in these cases. And also we have some immune stressors that anecdotally we think that may initiate a recurrence. Although HSV study showed none of these can be a factor in a recurrence. And in terms of local susceptibility, we can consider topical medications and surgery that we do in eye or around the eye. So in terms of the topical medications, for example, prostaglandin analogs like latanoprost, there are some reports that after initiation of latanoprost, patient gets epithelial keratitis. There are case reports. Still, we don't know how this is the importance of this, but common sense says that if we know that the patient has a history of recurrence, we should avoid the prostaglandins. And in terms of the corticosteroids, it's very obvious. The corticosteroids, either type, topical, intravitreal, or systemic, can increase the risk of recurrence. And also in terms of the angiogenesis inhibitor, VEGF inhibitor, like bevacizumab or ranocizumab, there are cases, reports of bevacizumab of intravitreal injection that cause epithelial recurrence of epithelial keratitis. Although we use this medication actually for the treatment of neovascularization associated with HSV keratitis, but still there are some reports. We don't know what's the importance of this. And in terms of trauma and surgery, the contact lens where HSV study didn't show any significant correlation, but in terms of laser surgery, particularly LASIK and laser refractive surgery like PRK or PTK, we may have a recurrence either epithelial or stromal. Particularly with the PTK or PRK, we may have more epithelial early after the surgery. With LASIK, we may have more stromal recurrence and later 2 or 3 weeks after the surgery. Also, it was reported as after YAG PI or YAG capsulotomy, ALT, and also it was reported after the cataract surgery and penetrating or lamellar keratoplasty. Also, with the surgery, we don't know if it's the direct association with the local trauma associated with the laser or surgery, or is because of the steroid that we use. But I want to a little bit focus on keratoplasty. We have 2 main reasons for graft failure after keratoplasty in patients with hepatic eye disease. One is viral reactivation, and the other one is simple allograft rejection. And most of the time, and some of the time, it's very difficult to differentiate these two. And for these reasons, patients with history of ocular HSV have a higher incidence of allograft rejection. And look at the numbers and the recurrence rate of HSV keratitis after PKP in patients without oral antiviral prophylaxis was reported about 30% at 4 months, 40 to 45% at 1 year, and almost 50% at 2 years. So it's very significant. And but patients that had prophylactic treatment with acyclovir, they showed fewer recurrences. I was going to give you some numbers again. If the patient with prior history of HSV keratitis undergoes either full thickness or lamellar keratoplasty, if we start the treatment for 3 weeks and continue only for 3 weeks, the risk of recurrence is about 30%. If you continue for 3 months after the surgery, the rate is about 18%. But if we continue up to 6 months, the rate drops to 6%. And if we continue 1 year, the rate drops to 0 to 5%. And that shows the importance of the prophylactic treatment in this patient. And in terms of the diagnosis, the main point here that, the main way of diagnosis of HSV keratitis is almost always for us is solely on clinical appearance of the cornea. Although we can detect the virus either through culture, PCR, or other tests, but testing most of the time is time-consuming, expensive, and the results come sometimes very late, and it might not be helpful to, and help us with the treatment. So mainly our diagnosis is clinical. And in terms of the treatment, so we have 11 antiviral agents that they have proven efficacy against HSV, but only 5 of them, 2 topical, trifluridine and ganciclovir, and 3 systemic, we can use them in the United States as a treatment for HSV keratitis. And I would like to divide the treatment in 3 categories. Therapeutic low dose, that's basically the conventional dose, acyclovir 400 milligrams 5 times a day that we usually use for the treatment of HSV keratitis. And we have the therapeutic high dose, acyclovir 800 milligrams 5 times a day that we usually use it for herpes zoster. And also we have a prophylactic dose of acyclovir 400 milligrams 2 times a day. And also we can have equivalent doses of valacyclovir or Famvir. But let me, for the treatment, I'm going to go with either with each category of the keratitis. For epithelial keratitis, 2 points that I would like to make. Oral antiviral agents are as effective as topical antiviral. Although FDA-approved medicine is ganciclovir and trifluridine. None of the systemic treatment antivirals are approved by FDA for treatment of HSV keratitis. So the approved treatment is ganciclovir and trifluridine, but oral antiviral studies show that is as effective as topical. And the other thing, there is no evidence that simultaneous use of 2 antiviral agents, whether topical or oral, accelerate healing of HSV epithelial keratitis. And in terms of how we can choose the treatment, so for epithelial keratitis, if we have a dendritic form, because it's the earliest stage and we think the viral load is low, we can go with the therapeutic low dose. Why? Because we have live virus here and the dose of the virus is low. So we can go either with the acyclovir 400 milligrams 3 to 5 times a day or equivalent of valacyclovir 500 milligrams twice a day, or famciclovir 250 twice a day for 7 to 10 days. Or we can go with the topical trifluridine, 1 drop 9 times a day for 7 days. And after that, we go to 5 times a day. And we shouldn't continue beyond 3 weeks because of significant ocular surface toxicity. And the better option is ganciclovir that we can use 5 times a day till the epithelium gets healed, and then we decrease it to 3 times and continue for 7 days. But if we have an epithelial keratitis geographic form, because this is a later stage, probably we have more virus and the virus load is higher. Some people, they suggest that we need to go with therapeutic dose. So we have live virus and we need to go with the high dose. And they suggested 800 milligram of acyclovir 5 times a day, and with the longer duration, 2 to 3 weeks, or equivalent dose of other antivirals, oral antivirals. Although the topical, again, the same as we already said about dendritic. And in terms of the stromal keratitis, as we know here, immune mechanism is the main mechanism. So the main treatment is going to be a steroid. So we're going to use the therapeutic dose of topical corticosteroid. I mean by therapeutic dose, prednisone 1% or equivalent of that, 6 to 8 times daily that we taper over 10 weeks. At least we need to use it for 10 weeks. Plus prophylactic dose of antivirals, because we don't have the live virus here. So we can use the acyclovir 400 milligrams twice daily or equivalent of other. And here with the prednisone, as long as the patient is under prednisone, we need to continue with the prophylactic dose of antiviral. And the prednisone, we gradually and slowly decrease the frequency and the dosage. And the lower we go with the dose and frequency, we need to increase the interval to find the, the safe final dose for that patient. And if we have, this is the stromal keratitis without ulceration. But if we have a stromal keratitis with ulceration, here we have live virus as well as immune mechanism. So here we go with a limited dose of topical corticosteroid plus therapeutic dose of high dose of antiviral, because we have low, basically the virus load is higher here. So we go with the prednisone 1% twice daily plus acyclovir 800 milligrams 3 to 5 times daily for 7 to 10 days. And as long as the patient is in the, and then after 7 to 10 days, we can go to the prophylactic dose. And as long as the patient on prednisone, we can continue with the prophylactic dose. And in terms of the treatment, basically, the steroid, basically how the patient clinically responds to it. There is no real study on stromal keratitis with ulceration for how long we need to continue with this. And in terms of the endothelial keratitis, here we have main mechanism is immune mechanism, although we may have some live viruses. So here we go with the therapeutic dose of topical corticosteroids as well as therapeutic dose of oral antiviral, although we can go with the low dose. So prednisone, again, 1%, 6 to 8 times daily, plus acyclovir 400 milligrams 3 to 5 times daily. And we can continue it with the 7 to 10 days. And as long as the patient is, and then after 7 to 10 days, actually, we can go to the prophylactic dose of the antiviral. And as long as the patient on the steroid, we need to continue with the antiviral prophylactic dose. And in terms of the prevention, HSV study has 5 different trials. I'm talking about the 5th trial that is look at the prevention. And the question was, does acyclovir, oral acyclovir prophylaxis minimize HSV recurrence? And they recruited 700 patients and they gave them 400 milligrams twice a day for 12 months, and they followed them for 18 months afterward. And it showed that it decreased the risk of recurrence stromal keratitis by 50%. So for that reason, long-term prophylaxis recommended for patients with recurrent HSV keratitis. So what else we need to know about the antiviral prophylaxis? The majority of morbidity we know that associated with the ocular HSV is due to the HSV stromal keratitis. So long-term, at least 1 year or more, low-dose oral antiviral is recommended for patients with history of recurrent HSV stromal keratitis. And the other potential indication, if we have multiple recurrence of any type of HSV keratitis, if we have a recurrent inflammation with scar and neovascularization approaching visual axis, if we have more than one episode of HSV keratitis with ulceration, because here we have a strong inflammatory response and it ended up with neovascularization, lipid deposition. And post-keratoplasty in patients with HSV-related scarring, or any other ocular surgery in patients with prior history of HSV, and in patients with history of ocular HSV during immunosuppressive treatment. And prophylactic treatment, as I mentioned, is acyclovir is the classic. It's 400 milligrams twice a day, at least for 1 year, or equivalent dose of valacyclovir 500 milligrams once a day, or famciclovir 250 twice a day. And although the duration we don't know, nobody really knows, but at least should be 1 year. Some people, they use this indefinitely. And in terms of, again, oral, one thing about the prophylaxis, oral antiviral prophylaxis is more effective than topical. We shouldn't use the topical as a prophylaxis. Other oral antiviral, because the classic one is acyclovir, but studies show that valacyclovir also is as effective as acyclovir. And recurrence actually is more likely in patients that they use lower doses than 800 milligrams daily. So if you are keeping a patient on prophylaxis dose, at least they should be on 800 milligrams daily. And in terms of the patient that they have ocular surgery, sometimes we need to go much higher for prophylaxis. Actually, a study showed that the recurrent HSV keratitis following ocular surgery, those that on higher doses, more than 400 milligram TID acyclovir, they experienced significantly lower recurrence than the patient that they use less than 1,000 milligram a day. So for that reason, if we are doing PKP, I would suggest oral acyclovir in doses of 800 milligrams 3 times a day. And some people, they suggested to continue for 4 months initially, and we can taper it to 400 milligrams twice a day, and we can keep it at least for 1 year. And some people, they say, as long as they are on topical steroid, we should continue with this prophylaxis. And my talk, the majority of this slides and the points that I brought, mainly I brought it from this article, the treatment guideline by James Chodosh, that's published by American Academy of Ophthalmology in 2014. And thank you for your attention. If you have any question at the end of this, I will be more than happy to, if I can, answer them. Thank you.
All right. Good evening, everybody. I hope you can see my slides okay and hear me okay. My name is Onkar Sawant. I'm Director for Research and Innovation at Eversight. And today I'm going to talk about our study on assessing effect of second betadine exposure on corneal toxicity and decreasing donor tissue fungal bioburden and its sequential impact on our clinical outcomes. So this study has been possible because of tremendous collaboration between different teams within Eversight and our collaboration with Dr. Ali Jalilian at Department of Ophthalmology at UIC Chicago. We like to start all of our presentation with our mission statement. So we restore sight and prevent blindness through the healing power of donation, transplantation, and research. So over the last 10 to 15 years, especially Eye Bank of Association of America has reported increasing trend in post-operative fungal infection after corneal transplantation. One of the reasons could be increase in endothelial keratoplasty procedures, but there has been increasing trend. Work done by CPTS, Corneal Preservation Time Study Group, showed that overall rate of positive rim fungal culture is somewhere around 1.9%. And out of those 1.9% cases, 6.7% of those cases go on developing post-operative infection. Similar to this, there has been other reports that has been published over the last 2 decades showing that post-operative positive fungal culture rate is somewhere between 1% to 2%. So to address this issue, really innovative work that was started by Georgia Eye Bank a couple of years ago, identifying if we could use double betadine soak procedure to reduce the fungal bioburden. And this work has been published in Cornea Journal in last year. Their study showed that if we increase the betadine soak time, it significantly reduces positive fungal and bacterial cultures. It caused no incidences of clinical fungal infection has been seen, and no change in primary graft failure rate was observed because of increasing the betadine exposure. However, there is a still gap in our knowledge about understanding how, if double betadine soak procedure is actually causing any epithelial or overall corneal toxicity. Some of our surgeons had raised concern about increasing this betadine exposure. And their concern is valid because there are a couple of studies done in different animal models, especially using a rabbit model, that has shown that if you inject betadine or povidone iodide directly into the anterior chamber at the concentration of 0.25 to 10%, it can cause endothelial toxicity. Therefore, our purpose for this study was to determine the effect of double betadine soak procedure on corneal toxicity at the level of epithelial and endothelial toxicity. Also assess the function of overall corneal health as a measure of corneal thickness during the during the donor storage preparation, and also evaluate the epithelial outcomes from our surgical procedure. So beginning from November 1st, 2019, Eversight did start double betadine soak procedure. So I'll present some of the data that highlights the epithelial toxicity. And then second purpose was to really provide quantitative data on positive rim culture and post-operative infection after implementing this protocol. So we undertook this research study where we procured donor tissues with single betadine soak procedure and then double betadine soak procedure. So in this study, left eye was recovered based on our old traditional method, and then the right eye was implemented for double soak procedure. So when it comes to eye banking operations and recovering donor tissue, generally before procuring any ocular tissue, we perform fornix swab using 5% povidone iodine solution. Then after that, lid margin procedure is performed. And then directly 1.5 ml of betadine is added onto the eye. We wait 5 minutes before performing eye irrigation, and after that conjunctiva is removed. Before we would remove the after conjunctival removal, we will proceed with corneal excision. But with our new procedure, after removing conjunctiva, now we are adding additional 1.5 ml of betadine directly onto the ocular surface, and then wait another 5 minutes and perform second eye irrigation, and then proceed with corneal excision. So for this research study, we had side-by-side comparison with single and double betadine procedure. After that was done, tissues were sent to the research lab, at our research lab, where research technician who was blinded for the treatment group label all these donor corneas with calcium AM as marked by green dye here, which is an indicator of live cells. And we also mark these corneas with propydium iodide, which is a marker for dead cells. And you can see here this image from Leica fluorescence microscope showing green live cell and red dead cells from corneal epithelial surface. So we perform, as I mentioned, we procured left eye after single betadine soak procedure, and then right eye after double betadine soak procedure. So on the corneal surface, we took images at central cornea, peripheral cornea, and around the limbus. And as I mentioned, they were marked with calcium AM for live cells and propydium iodide for dead cells. And I hope you can appreciate that between left and right eye, we didn't see much differences for the density of these different live versus dead cells. We went ahead and measured number of cells, different dead and live cells in these images from 7 different donors, which was done as a paired analysis. So on this graph, this is a simplified data representation showing what percentage of epithelial cells were dead after this procedure and after undergoing the fluorescence staining protocol. So the bars on left side highlighted in blue are from single betadine soak procedure, and the right side bars are from double betadine soak procedure. And you can see through our hands, we see approximately 40%, 40 to 50% epithelial cell loss after this experimentation. And there were not really any significant difference between left and right eye, indicating that increasing betadine exposure doesn't really cause any additional epithelial toxicity. So we also wanted to analyze our clinical data retrospectively. So as I mentioned, we started double betadine soak procedure on November 1st, 2019. So we looked at data for 3 months after starting this procedure, and then from August to October 2019, 3 months before that. So between these 3 months time period, we had about 2,800 donor tissue recovered during this time period. So for all these 2,800 eyes in each group, after the recovery, very well-trained eye bank technicians perform specular microscopy to assess the epithelial morphology. And then based on the severity of exposure, we grade each tissue on the scale of 0 to 3, 0 being no severity on exposure versus 3 being most severe. So we observe mean or average severity of exposure for the pre or before about 1.48. And after implementing double betadine soak procedure for these close to 3,000 eyes, it was still 1.48. So somewhere between mild to moderate, nothing severe, and there wasn't any significant difference between before and after. We also measure total number of tissues with epithelial defects. So before we were having about 27% of tissue with any sort of epithelial defect. And after implementing, we actually also have just 26% of tissue. So again, no statistically significant difference before and after implementing the procedure. And then defect area restricted to about just under 6% for our before and after group. So again, indicating not a huge area that has any defect, but again, the numbers didn't change before or after, indicating that on our clinical cases, we didn't see any negative effect of increasing betadine soak time. So as I mentioned earlier, there was some concern or there has been literature in animal models showing betadine directly causes endothelial cell toxicity. Obviously on the donor tissue, we are doing it superficially, so there are less chances of betadine actually seeping into the anterior side. But you can see there wasn't any much difference between endothelial cell densities. So double betadine soak procedure, our average cell density used to be around 2,500. And before implementing this procedure, we are still in the same range without any statistical significant differences. And then prelamellar thickness on all of our DSEC tissue is a good indication of how overall corneal health may be affecting. And you can see before it was average prelamellar thickness was 522 micron, and after that it's 520. So pretty comparable data before and after. And this is just a representative image from our research study that we did. So here we are looking at endothelial cells stained with calcium AM, which are live cells, and a few red dots you can see in between. Those are from dead cells onto the endothelial side. And you can appreciate that there is not much difference on the endothelial cell density for live cells between single soak versus double soak. So next question we wanted to ask how it's actually affecting our positive rim culture data. So after we provide tissue to our surgeons, they send the cultures out and we get the report back about how many of those tissues came positive. So here on x-axis, I have data from starting from December 2018 to October 2019, 9 months period. So that is before implementing double betadine soak procedure. And then the data point highlighted after or from November 2019 in orange dots here are after implementing the double soak procedure. And I hope you can appreciate that our overall positive rim culture rate has gone down significantly after implementing this additional betadine soak procedure. And obviously there is a COVID-19 pandemic has taken effect here. So our numbers could be affected by that. But again, this is a percentage number. So all the data points were normalized for how many surgical tissue we provided. So just to simplify this data a little bit more, what we did, we clubbed all the data points together from December 2018 to October 2019. where we had average positive rim culture rate around 1.2%, similar to what has been reported by previous studies as well as CPTS work. But since November 2019, our positive rim culture rate has dropped down somewhere close to 0.4%. And then this difference is very significant. So going forward, we are going to continue evaluating this. Obviously, we need more data points to see how the long-term numbers are for positive rim culture rate are affected by double betadine procedure. But nonetheless, I would like to highlight that we have not received any post-operative infection being reported to us after November 2019, which is a great point. So with that, just to summarize what our data shows, that increasing betadine exposure does not cause any additional epithelial or endothelial toxicity or overall corneal toxicity. And it seems like it appears to decrease the incidences of corneal rim contamination. So that's pretty much from my side. Thank you so much for listening. And I will pass this back to Michelle.
Great, thank you. So as I mentioned earlier, if anyone does have a question, you can type it into the Q&A panel, and Dr. Dastjerdi or Dr. Sawant will answer your question. Okay, it looks like we have a question for Onkar. In regards to the double povoiodine rinse, do you know how it compares to what other eye banks are doing?
Thank you for that question. So I don't have a complete answer. I know EBA does recommend this procedure. As I mentioned during my presentation, I know Georgia Eye Bank does implement this procedure. So right now, I think since we were one of the early adapter for this. So November 2019 is when we started. I think there are a couple more iBank that has started implementing this procedure. It's just I don't have the exact information with me.
Okay, we have a question from Dr. Jalaj. How soon after an initial stromal keratitis episode with scarring will you wait to perform a PKP?
This is a really difficult question. As much as I know, nobody can really know, but some suggestion as if 1 year patient is free of any recurrent episodes, we can consider doing surgery. That's at least 1 year that I heard, but there is no study. Actually, I looked for this multiple times to find out, but I couldn't find a very definitive answer to this. But this is something that anecdotally, and I heard from many other corneal surgeons that they wanted to wait at least 1 year before they do the surgery. At least 1 year, patient without any recurrent episode.
So it looks like that will end our webinar. I'd like to thank everyone again for joining us this evening. The webinar has been recorded and will be available on our website to view on demand if you'd like to go back and view it. A very special thank you to Dr. Dastjerdi and Dr. Sawant for serving as today's speakers and providing us with your invaluable expertise on these subjects. I hope everyone has a wonderful evening. Thank you.
Thank you.
Thank you.
Michelle.